to introduce the speaker of this evening's live webinar, Pathophysiology of Diabetes. This topic is being dealt with by Dr. Muralidhar Kanchi, who is the Director, Academics, Senior Consultant and Professor of Anesthesia and Intensive Care at the Narayana Institute of Cardiac Sciences, Narayana Health City. He is also Professor of International Health at the University of Minnesota, USA, and the Dean of the Indian College of Anesthesiologists. He is the Principal of Narayana Hrudalaya Institute of Allied Health Sciences. And there we have amidst us a very, very distinguished speaker who will be telling us about the pathophysiology of diabetes, a very essential and important topic of the day. With that, over to Dr. Muralidhar Kanchi. Please, sir.
Ladies and gentlemen, good afternoon to all of you. And thank you, Dr. Shanmukhanandam, for introducing me. And I would like to thank the ANBI, that is the Association of National Board Accredited Institutions, for arranging these topics on a regular basis. These topics are relating to basic sciences, which are most often neglected in the training program. This is a good review of the basic sciences, which we have learned in our MBBS. We are refreshing our memory so that we can apply the basic science knowledge to the betterment of the patient's care and a better understanding of the pathophysiology, management and treatment of patients. That is the whole idea of these webinars. These webinars are being held every Tuesday from 3:30 to 4:30, covering entire spectrum of basic sciences. Today we'll be discussing about diabetes pathophysiology. This is essential even if you do not belong to the category of DNBs from endocrinology or general medicine. A basic understanding of diabetology is needed for all healthcare professionals because it's very, very common ailment which the mankind suffers from. If you look at the statistics, it is clear that it's a huge problem world over. And this is the 2019 statistics from the World Health Organization, which clearly tells us that there are 422 million diabetic patients all over the world, and this is on the rise. The number is on the rise. And 1.5 million deaths are caused by diabetes alone. So it's a serious issue. And as we are progressing into the 20th century, in fact, the next century, the incidence of degenerative diseases and metabolic diseases like diabetes is going to rise, and we are going to have an explosion of these diseases. And it is vital for us to understand why it occurs, what are its manifestations, how to diagnose it early and control it, and have a good quality life despite having the disease. So once the disease starts, it's almost for lifelong, and you have to change your lifestyle so that you have a better quality life despite having the problem. So you can control it. There's no real cure for diabetes as of now, though some success have been achieved with islet transplantation, etc. But in general, there is no cure for this. Only thing is we can control it and have a good lifestyle and enjoy the life which has been blessed to us by the Almighty. So coming to the definition of diabetes, there are two words, one from Greek and one from the Latin, which is used to derive this terminology, diabetes mellitus. Diabetes meaning to pass through a siphon, and mellitus meaning sweet, which clearly indicate that you're passing a sweet sort of urine in this disease. It is a metabolic disease because of lack of insulin, which can be absolute or relative. There is a relative or absolute lack of insulin because of various reasons. And if you look at the global burden of diabetes mellitus, I have already mentioned that it's on the rise. And in 2014, if you take the world population, 9% of the people who were above 18 years had diabetes, and and it is projected to be the seventh leading cause of death in 2030. That is, in about next 10 years, every seventh death will be caused because of diabetes. It's going to be a huge problem, and it is going to be an expensive problem because the expenditure on health, if you take up to 12% of the total expenditure is for diabetes. So it's a huge loss of exposure, and hence we need to pay attention to this, despite of the fact that you may be belonging to some other specialty, does not mean that you should not have some idea about diabetes, what are its manifestations. If you come to the Southeast Asian population, the highest prevalence rate is in Mauritius, followed by Sri Lanka and India. In India, about 10.4% of the people develop diabetes, and the number of people with diabetes in this region is expected to touch 150 million by 2045. That is 11.1% of all adult population beyond 20 years of age will be suffering from diabetes mellitus. What are the risk factors which determine the type 2 diabetes in South Asian population to which we belong to? This can be lifestyle and nutrition. As I said, as we are progressing into this century, we have become more sedentary. We use lifts to go up the stairs, and we use cars to go to buy vegetables. We sit in the house watching television and munching potato chips. All these things and we use grinders and other washing machines to do our daily chores. So these are all labor saving devices which makes us less physically active, and especially in our continent, that is in the Indian subcontinent, we have low level of physical activity, and sometimes the cardiorespiratory fitness is not as good as in the Western population. Additionally, coming to body composition, high body fat as compared to Caucasians, even though the body weight may be same, the body fat content is higher in our subcontinent. There is abdominal adiposity, there is excessive fat in the liver, and low beta cell reserve in the pancreas, less brown fat, and sarcopenia, that is low muscle mass. If you compare a person of the same body weight from Indian subcontinent to a Western subcontinent, the muscle mass is greater in the person who is from the West. And other causative factors are vitamin D deficiency, and atmospheric pollution also is expected to increase the incidence of diabetes in our subcontinent. So if you look at the age group, 70 to 79 has the highest incidence of diabetes. This one is in the males. Second column refers to females, and third column is the total 13.2% in this report generated last year in National Diabetes and Diabetic Retinopathy Survey clearly indicates that the incidence of diabetes in our country in this population is the highest, reaching almost 14%. And if you take the state-wise distribution, the highest incidence is reported in Kerala, followed by Chennai, then Hyderabad, Karnataka, and then if you look at Guwahati, it's very low as compared to others. It's about 8%. And in Rajasthan, again, it is less. In general, South India is more prone to diabetes as compared to North, probably related to use of rice as a staple diet, and we use rice and rasam, which has nothing but water, tamarind water, whereas in north they use roti and dal. So that is a little more balanced probably. That's one of the reasons why we are seeing more diabetes in southern states. So please keep this in mind. And when we look at the patient's preventive aspects, we need to explain to the individuals to have a balanced diet so that there is no excess carbohydrate intake. Coming to types of diabetes, we have basically two types, type 1 and type 2, but now we have added other types. Initially, in the earlier days, the type 1 was called as insulin-dependent diabetes. Now it is changed, its terminology is changed. It's called type 1 diabetes. And we have type 2 diabetes, which was initially called as non-insulin dependent diabetes. Now we call it as type 2 diabetes. The major difference is that in type 1 diabetes, there is no insulin. There is almost zero insulin in the body, and the patients here depend upon insulin to be given. Otherwise, they will get ketoacidosis and they may die if not taken care of uh, uh, quickly and treated in a hospital setting. Whereas type 2 diabetes, it is not because of insulin deficiency. It's actually there is insulin is present, but it is not acting. There is a sort of insulin resistance. So that is what is type 2 diabetes, which is uh, there is insulin resistance. The third type is gestational diabetes mellitus, where it is in women who are carrying babies in second and third trimester pregnancy. There may be diabetes. And the other fourth type is miscellaneous causes, which includes maturity onset diabetes of the young, which is called MODY, maturity onset diabetes of the young. If you take the short form, it is called MODY. And we also have diabetes due to pancreatic problems. So, for example, patient has fibrocystic disease of the pancreas or has chronic pancreatitis or any disorder of the pancreas where beta cells are affected. It is a organ-related disease. It's not a metabolic disease in this case, but it is because of pancreas is damaged. In these cases, they have diabetes, and sometimes you have drug or chemical-induced diabetes. And here we also can include diabetes because of hormonal problems. For example, you have thyrotoxicosis, or you have Cushing syndrome, or you have acromegaly. These patients, these cases develop diabetes not because of primary pancreatic beta cell problem, but because of there is some other overriding reason for the blood glucose to be elevated. That's why they develop diabetes. So basically, for our understanding, would suffice to know that there is type 1 diabetes, where there is almost virtually no insulin in the body or very minimal amount of insulin because of autoimmune destruction of the beta cells in the pancreas. The type 2 diabetes, where there is insulin is produced, but it's not able to act because of tissues have become resistant to the effect of diabetes insulin. So the insulin is present, but it is not able to act. This is the type 2 diabetes. This is the broad definition, but there are several subcategories. If time permits, we'll go through them. How to diagnose diabetes? For diagnosing diabetes, we have to look at the fasting plasma glucose. Please note that it is plasma glucose because there's a difference between capillary glucose and plasma glucose. Plasma glucose is usually derived from the venous sample obtained from the antecubital vein in a routine testing in a phlebotomy in a hospital setting. This is fasting plasma glucose, not the capillary glucose. Capillary glucose is derived by finger prick technique. So please note this difference. Though you can use either of them, but for definition, you have to use the plasma glucose. If the plasma glucose is more than 126 milligrams per cent, that is more than 7 millimoles per liter, this is one of the diagnostic criteria. Or If the postprandial plasma glucose after 2 hours is more than 200 milligrams per deciliter or 11.1 millimole per liter, it also qualifies to be called as diabetes mellitus. And we also look at the random plasma glucose if it is more than 200 milligrams with symptoms and signs of hyperglycemia like polydipsia, polyuria, polyphagia, tiredness, etc. This also is one of the diagnostic criteria used. And importantly, what is called as glycated hemoglobin more than 6.5%. Glycated hemoglobin is the glucose attaches to the globin molecule of the hemoglobin. And if this goes beyond 6.5%, this is also a diagnostic criteria. Normal value for glycated hemoglobin is less than 5.7 grams. So if it is between 5.7 to 6.5, it's a pre-diabetic state. So these patients will develop diabetes in subsequent years. So you have actually euglycemia when the HbA1c is less than 5.7. Pre-diabetic state, if it is between 5.7 to 6.5, and diabetic state if it is more than 6.5 grams per cent. So these are the values which have been put forth by the American Diabetic Association guidelines, and these are validated and used worldwide for the diagnosis of diabetes. This glycated hemoglobin tells us about the control of diabetes in the last 8 to 12 weeks. So it indicates how the patient has been behaving in the last 8 to 12 weeks. So it's a monitoring tool as well as diagnostics tool. If you are monitoring diabetes during treatment, we can use HbA1c as a parameter to be checked periodically to be able to say that if the diabetes is controlled or it's out of control. That is the monitoring. Diagnosis also can be based on hemoglobin A1c by looking at the values less than 5.5. 5.5 or 5.7 is normal, that's no diabetes. 5.7 to 6.5 is pre-diabetes, and more than 6.5 is diabetes. But we should know that there are some conditions which are associated with falsely low or falsely high hemoglobin, that is HbA1c levels. These are listed here. Conditions which are associated with increased RBC turnover like hemolysis, hemorrhage, venous section. If you're drawing the blood very rapidly, hypersplenism, recent blood transfusion, G6PD deficiency, some drugs like antiretroviral drugs, and hemoglobinopathies. This will have the falsely low hemoglobin, the HbA1c, whereas it may be falsely high in iron deficiency anemia and postplenectomy. What are the problems with glucose? Why are you worried about the glucose being high in the blood? Their glucose itself is toxic because high levels can promote non-enzymatic glycolization reaction that lead to the formation of abnormal proteins. These proteins may weaken the endothelial junctions and they will cause decreased elastance, which is responsible for stiff joint syndrome. And if you check with anesthesiologists, they will always say that chronic diabetic patients may have difficulty in intubation because their joints have become stiff and the atlanto-occipital joint is fixed. So the ideal intubating conditions are not achieved because of this problem. So be aware of this problem. And the other thing is that there is increased production of macroglobulin in the liver, which promotes intracellular swelling, favoring the production of non-diffusible large molecules called sorbitol. And this is again a problem. And the third problem is that the hyperglycemia disrupts autoregulation. That is, the glycosylated hemoglobin level of more than 8.1% is a threshold at which microalbuminuria increases logarithmically. And a person with type 1 diabetes who has microalbuminuria of greater than 29 milligrams per day has 80% chance of experiencing renal insufficiency. These are all the facts which have been demonstrated in patients with diabetes, and hence it is important to keep the diabetes under control. And one more physiological factor is that diabetes, if it is not controlled well, advances the physiological aging. We have what is called as chronological aging, and that is biological age. So chronological age is dependent upon the date of birth and the number of years you have lived, whereas biological age relates to the health of your tissues. So these two things are usually coincident in a given person if he is healthy, or actually biological age may be um, less in a patient who is actually aged if his lifestyle is good. But in these patients who have diabetes, because of accelerated physiological aging, if a person has type 1 diabetes with poor control, he is 1.75 years greater aged, physiologically speaking. That means that if a person develops type 1 diabetes at the age of 10, and if it is poorly controlled, at the age of 20, he will be actually 27-year-old. His tissues will become 27-year-old. Similarly, if you have a type 2 diabetes and you are developed diabetes at the age of 50, and if the diabetes is not controlled well, by the age of 60, you will be actually 65 years. For every year of 1.5 years of age, your chronological, the biological age advances by 1.5 years. So these are all important factors which must be understood when we look at the patient. So if you encounter a patient who is actually 6-year-old by date and he has been diabetic poor control, actually his tissues will be 70 or 80-year-old. So the factor must be included in when we are considering the treatment options in these patients. And we also should know that there is what is called a C-peptide, which is a product of cleavage of pro-insulin. So the insulin is produced by beta cells in the pancreas. When it is produced, it is attached to what is called a C protein, but when it's secreted, the C peptide is cleaved and that will be released in circulation. And this is important not for diagnosis, but it tells us whether the beta cells are functioning or not in a given patient. Suppose if we have C peptide, it means that insulin is being produced by the body. But if C peptide is not there, it indicates that insulin is not being produced. So it is a factor which can be differentiating type 1 and type 2 diabetes. And coming to type 1 diabetes, there are 4 main antibodies which are responsible. You develop these patient, type 1 diabetes patient develop autoantibodies against beta cells in the islet of Langerhans. So our own body produces antibodies, that is the patient's body, destroys the beta cells, and then the patient develops type 1 diabetes. These are the types of autoantibodies. And up to 90% of type 1 diabetes patients have at least one positive antibody, which is mentioned here. And there are two subtypes of diabetes mellitus, which does not really fall into type 1 or type 2. In the sense that this is called MODY, not Indra Modi. This is called MODY, maturity onset diabetes of the young, where there is strong family history of diabetes. It has an autosomal dominant inheritance. Though it is a maturity onset, the age of onset is below 25 years. And the important factor is that they are resistant to ketoacidosis, and you can control these patients with oral hypoglycemic agent. This is in strict contrast with typical type 1 diabetes, juvenile onset diabetes, where the patient is less than 20 years and they need insulin, and oral hypoglycemic agents are not able to control the glucose in them. But this is a different type of diabetes called MODY, maturity onset diabetes of the young. The second variant variety is called as latent autoimmune diabetes in adults. This is similar to type 1 diabetes, but it is occurring at 25 years or more than that, and these patients are non-obese, and they are initially well-controlled diet or diet plus oral hypoglycemic agents. So these are the two different types. So when you look at diabetic patients, when you want to diagnose the type of diabetes, we have to see the age. Age is less than 30 years, more than 30 years, or any age. What is the body mass index? Is there any pancreatic problem? Is there any autosomal dominant inheritance? Is this associated with obesity or acanthosis nigricans? Or is there any association with genetic syndrome? Depending on that, you can classify them to type 1 or fibrocystic pancreatic disease, maturity onset diabetes of young, or polycystic ovarian disease, or secondary diabetes. And then further investigation can be done to be able to come to a conclusion on the type of diabetes you are dealing with. If the age is more than 30, it can be type 2 diabetes or gestational diabetes in women, or it can be LADA, which we described in the last slide, latent autoimmune diabetes of the adult. And at any age, you can look at the etiology and classify them into the type of diabetes. This is important because if you want to treat these patients appropriately, we have to know what type of diabetes we are dealing with. Because one sort of treatment may not be suitable for all patients. So one size does not fit. So we have to know what are the various types of diabetes which are mentioned in the third column here, and how to investigate and subcategorize them, which is mentioned in the fourth column. And then depending on the category, we have to tailor make the treatment options. For the optimal function of all organs, especially the brain needs glucose. So whenever you are hungry, you will not be able to digest what you're eating. So you must have optimal level of glucose. Brain needs glucose that is maintained within a narrow normal range, that is 80 to 120 milligrams or 60 to 90 milligrams, depending upon the type of blood sugar you're measuring. And there is a well-coordinated action of all hormones involved in glucose metabolism. The hormones are mentioned here. Insulin on the left side, you have the hormones. And effect of these hormones on the blood glucose levels is on the right side. We have insulin, glucagon, glucocorticoids, growth hormone, catecholamines, and thyroid hormones. The accepting insulin, all of them increase the blood glucose, whereas insulin is the only one which decreases blood glucose because it is anabolic. Anabolic means it increases glycogen synthesis. It takes the glucose and makes it into glycogen. It causes lipogenesis. That is, it increases the adiposity. And it also causes protein synthesis. That is, it brings about the increase in the protein mass in the body. So this is anabolic effects. And it inhibits gluconeogenesis. That is, it does not permit the conversion of proteins and lipids into glucose. And it prevents glycogenolysis. That is, it prevents the breakdown of glycogen and also prevents the breakdown of proteins. And it inhibits the breakdown of fats. So all these things are necessary to be able to maintain the blood glucose in the normal range. Whereas the glucose enters the cell and is usefully utilized for the metabolic and the daily cellular requirement. Just like rice and dal is coming into the house, which is being cooked and we eat it. Similarly, insulin is a facilitator for the metabolism inside the cell. The glucose enters the cell and it is used for the energy production, which is useful to maintain the cellular functions. And if you look at the structure of the insulin, it's a polypeptide hormone synthesized in the endocrine part of the pancreas, that is beta cells of the pancreas. And pancreas is basically exocrine organ, but it has the Langerhans cells as alpha, beta, and delta cells, which are involved in production of hormones. Alpha cells produce glucagon, beta cells produce insulin, and delta cells produce somatostatin. So we are basically interested in insulin, which is a polypeptide, and there are two sulfide bonds which are joining the alpha and beta chain, that is A and B chains. And whenever we ingest sugar or glucose, there is a biphasic insulin response. First phase is short-lived; it lasts for about 5 minutes. And this is related to insulin release from the preformed secretory granules in the beta cells in the pancreas. And the second phase is a bit longer and it lasts for about 2 to 4 hours. And it is related to the release of insulin as a result of production or synthesis of insulin as a result of the action of what is called incretins, and also because of synthesis induced stimulated by the ingestion of glucose. The metabolic effects of insulin, I already mentioned about the glycogen synthesis, inhibition of glycogenolysis, inhibition of glyconeogenesis, and stimulation of lipogenesis. And the insulin increases glucose uptake by stimulating GLUT4 transporter in the plasma membrane. GLUT is nothing but a substance which enhances, it is glucose transport protein, which improves the intake of glucose inside the cell. And we need to know a little bit of incretins. These are hormones that are produced by the interstitial epithelium. So when we ingest glucose or carbohydrate right in the intestine, the incretins are released, which the blue one represents the incretins, which increase the insulin secretion from the beta cells of the from the pancreas. But this does not happen if you are giving intravenous glucose. This is shown in the green part of the curve. This is the time, and the plasma insulin level increases because of the release of incretins, which are produced, which are actually hormones that are produced from the intestine in response to a glucose meal or carbohydrate meal. There are two important hormones in this group. These are called as GLP, glucagon-like peptide 1, and glucagon-dependent insulinotropic peptide, GIP. These are the two hormones which are produced by the intestine in response to a carbohydrate meal, and this enhances insulin production, secretion, and responsiveness. So once you ingest carbohydrate, there is release of the incretins, which we said that glucose-dependent insulinotropic peptide and glucagon-like peptide 1 are released, which increases insulin secretion from the beta cells, which in turn increase the glucose uptake by muscles and reduce the glucose reduction by liver, leading to control of the blood sugar. And in the pathogenesis of type 2 diabetes mellitus, there are 8 factors which are involved which may be working simultaneously, or one may be little more than the other, which are responsible for the increase in the blood sugar, that is hyperglycemia. These are increased glucagon secretion from the alpha cells, decreased insulin secretion, decreased incretin effect, breakdown of lipids, increased glucose reabsorption from kidneys, decreased glucose uptake, neurohormone transmitter dysfunction, increased hepatic glucose production. All these 8 things are working more or less simultaneously. One may be more in one given particular circumstances, but all of them invariably cause hyperglycemia and lack of control of diabetes. In type 2 diabetes, we have a sort of resistance to insulin. Though insulin may be present in the body, it is not able to act properly, and the factors which produce insulin resistance are overweight or obese individual. Overweight means the body mass index is between 25 to 30. Obesity means its body mass index is more than 30. Physical inactivity, physiological stress, especially puberty, etc., or drug intake such as steroids, other endocrine disorders, infections. Low birth weight has been postulated to produce to insulin resistance later in life. However, this mechanism is not yet clear. So during younger days, if the person is taking less food, and when he becomes adult and he starts earning money, and he or she, it can be anybody, it's not sex specific. Once he or she starts to earn money, becomes a little more prosperous and starts to have food a little more than what he used to have when he was younger, the body may not be able to compensate for this, and the glucose is accumulating in the body. Body is not able to take care of the extra glucose which is being taken by the individual, and the patient develops insulin resistance and type 2 diabetes. And how to measure insulin resistance? There are standard method is called euglycemic clamp technique, but it is not routinely available in clinical circumstances. But what we can do is, if we can measure the fasting insulin, if we multiply that with fasting glucose and divide the product by 22.5%, you can get the level of insulin resistance. And coming to role of beta cell defect, beta cell dysfunction is a major factor uh, which converts pre-diabetes to diabetes. The problems of beta cell are mentioned here. There is inadequate insulin secretion, followed by hyperinsulinemia after carbohydrate meal. There is loss of pulsatility of insulin action, impaired sensitivity of beta cells to glucose, and beta cell apoptosis. That is, there is a programmed cell death in these beta cells. They program themselves and they subsequently die, and there is altered gene expression and excessive secretion of amyloid polypeptide. These are all the causes which cause beta cell defect, and the mechanisms are related to genetics, environmental factors, which include glucotoxicity, lipotoxicity, incretin axis dysfunction, and in utero malfunction. And coming to alpha cell dysfunction, glucagon secreted by alpha cell is antagonistic to insulin, and lowering blood glucose stimulates the secretion of glucagon, which promotes hepatic glucose production by stimulating hepatic glycogenolysis and gluconeogenesis and increase blood sugar. And the rise in blood glucose stimulates the cells to release insulin and promptly inhibits the glucagon to lower the blood glucose level. This inhibition is lost in type 2 diabetes mellitus, leading to hyperglycemia. Kidneys also play a very important role in glucose hemostasis. You know that kidneys have nephrons, and in the glomerulus, the filtration is occurring across the capillary epithelial membrane, which is at the Bowman's capsule, and the blood which is filtered, the glucose, all of that is reabsorbed. Most of it is reabsorbed in the proximal tubules, which is mediated by sodium glucose co-transporter called SGLT2 protein in the proximal tubules. And the presence of hyperglycemia augments the expression of the activity of this protein, that is the sodium glucose co-transporter 2 protein in the proximal tubules, which further increases glucose absorption by 20%. So there is more absorption of glucose in these patients, leading to hyperglycemia. Though the patient may develop glycosuria, some of the patients the threshold may be increased, and then the body actually accumulates the sugar or the glucose in the blood, leading to hyperglycemia. In the recent years, there has been a substantial development in the understanding of the different pathways that are leading to chronic complications. We'll just touch upon this. Actually, I would like to discuss about the complications in relation to emergencies, that is diabetic ketoacidosis, non-ketotic acidosis, all these things, non-ketotic hyperosmolar coma in a subsequent section, but I'll just make a passing mention of the pathogenesis of chronic complications, how these chronic complications occur. We'll be dealing with the complications and treatment options in a subsequent session, but here I will touch upon the causes for morbidity and mortality in persons who develop diabetes. And this is because of chronic complications. The target organs are damaged, and this is primarily seen in those organs where glucose uptake is independent of insulin and where cellular glucose concentration is directly related to the blood hyperglycemia. Virtually every organ is affected, but common sites involve eyes, kidneys, nerves, heart, and the blood vessels. So we have the eyes, kidneys, nerves, heart, and blood vessels involved in the pathogenesis of chronic complications. The diabetic retinopathy and nephropathy are basically related to microangiopathy. And cardiovascular disease primarily related to macroangiopathy, but it does not mean that all the cardiovascular problems in diabetes are because of macroangiopathy, because we develop diabetic patients develop cerebrovascular disease, which may be occluding, may lead to premature atherosclerosis in the cerebral vasculature or the coronary arteries, and they may cause obstructive lesions leading to strokes and thrombotic strokes in case of central nervous system, and acute MI in case of cardiac system, that is heart. And neuropathy is the combination of both micro and macro angiopathy. The mechanism of complications is highlighted in this slide. The chronic complications occur as a result of activation of pathways which are not normally active, or they are present but they are not very strong. But because of diabetes, they take the upper hand and cause chronic complications. For example, there is increased activation of polyol pathway where there is production of sorbitol, and there is production of advanced glycation in products leading to, for example, you get more when the hemoglobin is glycated, it becomes you get greater concentration of hemoglobin, glycated hemoglobin, that is the HbA1c, and you also have diacetyl glycerol protein kinase activation, that is PKC, and increased activation hexosamine pathway. And this is the biochemical pathway of glucose causing sorbitol, which is an alternate pathway for glucose metabolism, which is actually inactive in normal healthy situation, but it is activated in patients with diabetes, and this causes problems in nerves, retina, lens, glomerulus, blood vessels, etc. And this hyperglycemia can, the blood sugar which is there in the blood can take either of the pathways mentioned here. Glycation pathway leading to cytokine generation and inflammation. Sorbitol pathway leading to oxidative effects. And activation of protein kinase is responsible for complications associated with vascular integrity. And in conclusion, I would like to mention that pathophysiology of diabetes is important to understand, to be able to know how the diabetes affects the various organs. We need to know what are the types of diabetes. To start with, we need to know what is the definition of diabetes. Secondly, we measure the plasma glucose concentration to diagnose diabetes, and also take the aid of hemoglobin, that is HbA1c levels for diagnosis. Then we need to know what are the other variants of diabetes, that is MODY and GLADA. We said MODY is maturity onset diabetes in young, GLADA is autoimmune latent adult diabetes and gestational diabetes. And we also have miscellaneous diabetes, the type 1 diabetes where there is lack of insulin, and type 2 diabetes where the insulin is present, or if there may be actually excess of insulin, hyperinsulinemia is present, but the insulin resistance, because of the insulin resistance, blood sugar does not come down, and there is failure of transport of insulin from the bloodstream into the intracellular compartment. After that, we need to know um, what are the genetic variants which are responsible for diabetes, and what are the risk factors for diabetes, type 2 diabetes, especially in terms of genetic components and the environmental effects. And then we need to know the um, pathways, which are the alternate pathways for glucose to take, which cause target organ damage in these patients. So with this, I would like to conclude the session. We have about 3 to 4 minutes for question answers. If there are any questions, please feel free to put them on the chat box. I'll be happy to address them. And thank you so much. Sometime later, maybe about 3 to 4 weeks later, I would like to deal with the diabetic emergencies and treatment of diabetes. Thank you once again. I'm seeing at the chat box, I'm not seeing any questions here. Viju Wilburn, would you like to comment anything on this diabetes? Why, even if you are not doing diabetology or medicine, you must know about this. It can be a problem in general surgical patients, emergency patients, orthopedic patients, gynecology patients, pediatric patients, family medicine. So you can encounter diabetes in any specialty in any form. So we don't have to become endocrinologists, but we need to have some basic knowledge so that we will be able to do the primary intervention at the primary care, and then if it is not sorted out, we could get the expert help. That is my impression. We all of us must know everything about diabetes, the basics. I mean to say basics of diabetes. What is the pathogenesis? What are the diagnostic criteria? How do you manage them, and what do you do when in emergency? We have serious emergencies with diabetes, which may be life threatening or limb threatening. Somebody with diabetes can lose a limb or lose eyesight or lose kidney function. So it's a very important problem. And hence I urge that all of us must know something about diabetes, despite the fact that it may not be your specialty. Any role of genetic testing in babies born to mothers with genetic gestational diabetes? So if baby will have MODY, does this mutation come up later? Very good question. Very nicely put up. It's a very important problem. We are actually developing genetic markers for cardiovascular diseases. Similarly, for diabetes and hypertension, there are markers even if the patient is not maybe a patient is a diabetic, maybe in infancy, we can look at the genetic makeup and predict the possibility of development of diabetes in these patients who are not yet grown up actually. So the genetic, so we understand that this interplay of genetics and environment in disease causation. It is combination of both these factors. It may be the genetics may be high in one case or low in one case, and environment be high or low in one case. So if the genetic component is combined with environmental factors, certainly that individual will get the disease. Same thing applies to diabetes. And if you are genetically prone, you can delay the onset of diabetes by lifestyle changes, but ultimately you might end up developing diabetes. So it is important to look at the genetic aspects as well. Thank you for that question. Another 1 or 2 minutes to go. Any other questions are there? Viju Wilban, do you want to say anything about diabetes in emergency patients? Can you unmute Dr. Viju Wilban?
Hi, sir.
Hi, hi.
Yeah, mostly in emergencies, what we see DK.
Yes.
That is this. And right now the cold season is there.
Right.
So most of them, we start them on steroids.
Right, yes, steroids.
Yeah.
One of the
So
causes for diabetes. Yeah,
insulin infusion.
hyperglycemia. Yes.
Insulin infusion and ruling out DK, HSS.
Right. If there are no further questions, we're just about to reach to the target time, 16:30. Because there is one other session starting at 16:30. I would like to thank the ANBI for this opportunity, and Dr. Shanmukhanandam, Dr. Viju Welban, Dr. Shakuntala Baliga, and others who have participated. And thank you for this opportunity once again. I would like to see you sometime later.
National Board. Yes, sure, sir. We from Anbai. Thank you so much for your time, sir, this afternoon.
Thank you so much.
And thank you all the participants.
Thank you very much. We'll see you sometime. See you sometime.
Sure, sir. Bye.
Thank you.